quite an honor to speak in this forum. You put together a very nice program, a very nice sequence. We're going to touch on some things that were spoken about earlier and hopefully go beyond a little bit. Today I'm going to talk about a clinical subject that's near and dear to my heart and also my mentor, Craig Moskowitz, is how do we cure more patients that have relapsed refractory aggressive lymphomas, most notably diffuse large B-cell lymphoma, the most common non-Hodgkin lymphoma. This is my disclosure slide. So by way of background for the group, it was 20 years ago, over 20 years ago, where patients with relapsed or refractory aggressive B-cell non-Hodgkin lymphoma were randomized with salvage chemotherapy in the form of high-dose cytarabine, dexamethasone, and cisplatin for 2 cycles. And then by random assignment in this 100-patient study, either received high-dose chemotherapy followed by autologous bone marrow reinfusion or continued DHAP. Again, this is in the pre-rituximab era. Most notably, this is autologous bone marrow reinfusion, and the incidence of non-relapse mortality in the transplant group was approximately 10% on this study. As Dr. Moskowitz will tell you on rounds, when he rounded on the transplant service, GCSF has impacted survival the most in this setting over the past 20 years. As you will see, we haven't moved the bar much, if at all. So we like to think of this in 3 phases for relapsed refractory patients that should be or that you feel are appropriate to approach with curative intent. One is salvage chemotherapy to induce remission. The second is the actual high-dose therapy and autologous stem cell reinfusion. And then the role of leveraging that platform for maintenance therapy is still a question. So what is the best combination chemotherapy in salvage? DHAP that was referenced before in the Parma study is the most commonly used program in European. The most commonly used program in Europe. The most commonly used program here in the United States is ICE that was developed here. Dr. Bertino is here as well as Dr. Moskowitz. So this study was reported in 2010 for patients with relapsed refractory diffuse large B-cell lymphoma. It was random assignment, 400 patients, to either rituximab and ICE or rituximab versus DHAP. For patients that were able to achieve a chemosensitive remission by CAT scan and collected an adequate amount of CD34 positive stem cells, they went on to high-dose therapy, and a second randomization was commenced with rituximab maintenance versus observation. There was no difference in the overall response rate to the 2 regimens, and actually no difference in progression-free or overall survival at the end. What was most striking and most sobering is for patients that were previously exposed to rituximab, which obviously is ubiquitous here in 2016, a third of the patients on this study did not receive rituximab with their initial induction. Only half the patients were able to achieve a remission. This is by CAT scan criteria, and again, at least a partial remission. Once you accumulated risk factors, including secondary age-adjusted IPI and early relapse or refractory disease, that response rate goes down precipitously. The Canadian group engaged over 600 patient study looking at an outpatient program of R-GDP, which is another platinum and gemcitabine containing program, versus R-DHAP, a very large study. This was reported recently by Dr. Crump. As you can see in the table by random assignment, there was no difference in overall response rate, and less than half the patients responded to salvage therapy. Other histologies were allowable on this study, although the vast majority were diffuse large B-cell lymphoma. And as you can see, extremely sobering progression-free and overall survival curves. So the question, what is the best combination chemotherapy in salvage? They're all the same, and we actually believe that any platinum-containing regimen with mounting evidence appears to be equivalent. Well, what about switching the anti-CD20? And this is going back in reference to Dr. Maloney's talk earlier today. Matt Matazar was our PI here at MSKCC for a large randomized international study looking at the next generation anti-CD20 ofatumumab versus rituximab in random assignment in conjunction with standard salvage chemotherapy. As you can see here, patients were restaged following 2 cycles to ensure lack of progression or stable disease, at which point they were removed. If they demonstrated evidence of a response, patients were mobilized off the 3rd cycle of therapy and proceeded to high-dose chemotherapy and stem cell transplant with curative intent. Here's the study flow, and I present this to look at the boxes in terms of the patients that actually proceeded to transplant. Approximately half the patients responded to salvage chemotherapy in each group. There was no difference in outcomes of the two curves by intent to treat. So it appears that substituting the monoclonal antibody did not make a difference. We have recently engaged in a CTEP-sponsored study combining rituximab and ICE with the BTK inhibitor ibrutinib that's been referenced in earlier talks. Patients with relapsed refractory diffuse large B-cell lymphoma in the phase 1 dose escalation study, including transformed histologies, proceeded on a 3+3 design, RICE for 2 cycles, restaging, with evidence of progression of disease taken off study, if not a 3rd cycle, and then on to consolidation, auto, allo, or other. This was intended for transplant-eligible patients, at least by physiology. The data is going to be presented at ASH on Monday in a poster session, 4198. The overall response rate in 17 patients by intent to treat was 71%. One patient was removed from study shortly after first cycle of therapy with grade 3 atrial fibrillation and tenuous performance status, and one patient progressed rapidly following first cycle of chemotherapy. Of note, 4 out of 4 patients of non-germinal center ABC phenotype by Hans criteria, the 3-marker IHC criteria, had a complete metabolic remission by PET scan, and 10 of 11 patients successfully mobilized hematopoietic progenitor cells off chemotherapy off the 3rd cycle. The one patient that failed to collect was in dose level number 3 and was coincidentally the only patient with HIV on study, and was dealing with a febrile illness at the time. To us, this made sense because of data that's been presented in previous talks around the multi-center phase 2 for single-agent ibrutinib. Excitement was generated in the activated B-cell phenotype with a 38% overall response rate in the multi-center study. In terms of other work that's been performed and developed here, SGN-CD19A is an antibody-drug conjugate that was referenced in earlier talks as a ADC with a MMAF conjugate to a linker with 4 attachment sites to a monoclonal antibody that recognizes CD19. The original phase 1 study was reported at ASH 2 years ago by Craig Moskowitz in 2 dosing formats, with the dose escalation up to 6 milligrams per kilogram every 3 weeks, and then a second arm of dosing every 6 weeks. In the relapsed refractory diffuse large B-cell population, there was a 55% response rate in patients with relapsed disease that generated excitement. The most notable toxicity was adverse events related to ocular toxicity, keratopathy. Patients required pre- and post-cycle ocular exams and were managed with steroids. As you can see by the bar graph on the right, the majority of these adverse events were grade 1 to 2. There was preclinical models to suggest in vitro and in vivo synergy with combination chemotherapy, including rituximab. The data suggested autonomous signaling contributes to interaction between R and SGN19A, and this supported testing in a combination chemotherapy strategy. Thus, a multi-center phase 2 is currently being conducted. This is MSKCC 16008. It is a multi-center effort with 100 patients targeted to be accrued with relapsed refractory diffuse large B-cell lymphoma. The primary endpoint is complete remission by modern functional imaging criteria. Patients will be randomly assigned between a control arm of R with ICE or investigational SGN19A and RICE every 3 weeks for 3 cycles of therapy. So the way that we're triaging patients here at MSKC at the time point when we see them prior to salvage therapy is if we determine that they're of age and physiology to be transplant eligible, we are using the Hans algorithm to triage patients with either non-GCB or ABC subtype to the ibrutinib RICE study, and currently germinal center phenotype down the SGN19A RICE study. The goal of these salvage programs is to achieve complete metabolic remission by PET scan. We recently reported our experience in the post-rituximab era of 129 patients undergoing salvage therapy with pre and post PET scans, and patients actually proceeding to transplant. So all these patients were chemosensitive by at least a partial remission on cross-sectional imaging. We found of all the pre-salvage traditional risk factors, including secondary age-adjusted IPI, stage, time to relapse, or primary refractory disease, that the one prognostic indicator was the ability to achieve a remission below SUVs of liver background or DOVO 1 to 3 with no separation between those three groups. Of note, we were somewhat surprised that DOVO 4 is still achieved. Approximately half the patients were still salvageable with cure, proceeding to high-dose therapy and stem cell transplant, but this was the singular significant factor that came out in this retrospective analysis with adequate follow-up. So in the first phase in salvage, again, sobering data from the CORAL study suggesting that we are only getting approximately half the patients into remission. Currently, we have 2 ongoing prospective studies. In the realm of transplant, there's been 1 large randomized study that was conducted through the BMT Clinical Trials Network 0401, investigating radioimmunotherapy-based conditioning with Bexar and Beam to a control group of R-Beam, and as you can see by the curves, there was no difference in the primary endpoint of progression-free survival. More mucotoxicity was observed in the radioimmunotherapy arm. Here at MSKCC, we were recently conducting a prospective phase 2 randomized study wherein many centers have reported the prognostic significance of higher stem cell dose at reinfusion and outcomes. We retrospectively looked in our database with patients that received greater than 6 versus less than 4. The average is approximately 4 times 10 to the 6 CD34s per kilogram, with a trend towards significance, which was also observed in the International Bone Marrow Transplant Registry. The important point about all these studies and analyses is that it's all retrospective. Typically, in this clinical realm, what we collect is what we give, so better patients do better. But this has never been investigated prospectively in this space. Currently, we recently opened the randomized phase 2 study sponsored by Sanofi with provision of plerixafor to hypermobilize patients to greater than 7 million stem cells with a randomization in a randomized phase 2 fashion of high versus low dose. The low dose is the average of what we reinfuse in patients currently. The primary endpoint is a hard 2-year PFS that uses a historic control in composite of the CORAL study as well as the BMT CTN 0401. There are stopping rules if we're unable to mobilize a sufficient number of patients to greater than 7 million stem cells. There are many secondary endpoints that we're interested in light of retrospective data that have been performed at other centers. Most notably, the absolute lymphocyte recovery early post-transplant. Dr. Parada at the Mayo Clinic has really kind of made a career at analyzing this data. This is a very small study of 50 patients looking at ALC recovery 15 days following autologous transplant with highly significant prognostic impact of NK cell phenotype recovery post-transplant with very wide separation of the Kaplan-Meier curve, suggesting that there may actually be a autologous graft versus lymphoma type effect in this platform. We have actually looked at KIR, NK, and HLA compound genotyping in an autologous transplant platform here at MSKCC for neuroblastoma following high-dose therapy and a monoclonal antibody. Because the HLA and KIR separate on different chromosomes, some patients can actually have a missing ligand type phenotype, and within this nearly 180 patient study, there was significant impact of missing ligand phenotype, which could potentially serve as a prognostic factor or even a risk-adapted model for patients that you're considering alternative consolidation, i.e. CAR-modified T cells or an allogeneic transplant. So within the transplant space, we're currently investigating stem cell dose and potentially revealing correlative studies. Lastly, in the maintenance phase of treatment delivered with curative intent for relapsed refractory patients, the second randomization of the CORAL study rituximab maintenance versus observation only. As you can see in the curve on the right, there was no difference in outcomes. We still would like to know if we can explore this or leverage this platform as a potential platform for further immunotherapy. This data was reported a number of years ago with an anti-PD-1, pitolizumab, which may or may not be an anti-PD-1 per the company, with somewhat encouraging data in an early phase study. Many of these patients had positive disease proceeding to transplant, so seemingly by observation, these curves may exceed what would be expected outside of the adjunctive therapy. Currently, we're enrolling a study with our local PI of Dr. Dahi in collaboration with Philippe Armand at the DFCI in a phase 2 of pembrolizumab following high-dose therapy and autologous stem cell rescue in patients with DLBCL, HL, and a third arm actually for T-cell non-Hodgkin lymphoma has been opened, and data is pending. So we think we're sort of filling all the holes here. We currently have the pembrolizumab maintenance following auto transplant. Later this afternoon will be the CAR show, and I'll go over some data regarding MSKCC12117 of CAR-modified T cells following high-dose therapy. So, giving this talk, I was trying to think of a clever lyric or some sort of golf quip, and I just realized it wasn't going to happen. No one can match Craig. But I pulled up, I believe, the original ICE paper. Dr. Bertino is sitting here, and it's appropriately bookended by Craig and Andy, who have been terrific mentors. When I came here in the mid-aughts as a fellow, it's, sitting in the lymphoma tumor board, you kind of feel like you're here. So it really feels great, and obviously ICE lives on. So thank you, Craig and Andy. Some other